Hi, hello, this is Dr. Madeleine Muller, and welcome to the CMH Family Medicine Top Tips and Tutorials. Today, we're going to talk specifically around the treatments that we have available for schizophrenia and some of their major adverse events. And then in the last little module, we'll actually look at how we put it all together in terms of a treatment plan. And unfortunately, there's not been much advances in the world of psychiatric medication, or well, certainly not within what we have available in the public sector. So although there's a little bit of exciting stuff happening in the private sector, we still have a very old set of drugs available. And haloperidol is still one of the major drugs that we use as part of one of our first generation antipsychotics. And the biggest reason why we don't like it is because it has this extrapyramidal side effect. So higher risk of epilepsies, you have to watch those closely. And it's quite sedating. In some patients, that's quite a good thing. So if you've got a patient who's very agitated or struggling to sleep at night and up all at night, then haloperidol will probably be your first choice. Also, just to note that it can put your prolactin up. So that means you can end up having, for example, leaky nipples, for example, and it can have an effect on sexual dysfunction, which our young men certainly don't like. But it doesn't have that many anticholinergic side effects, which is quite nice. And it's not so bad in terms of weight gain and metabolic effects, which is a problem with some of our second generation antipsychotics. And then we always have to mention neuroleptic malignant syndrome, but that's quite uncommon. So the thing you need to remember with haloperidol, a bit more side effects, a bit more sedating, but the long-term use a little bit safer from a heart point of view. So actually, if you've got an elderly patient who's got diabetes and metabolic syndrome and is a bit restless, then haloperidol is actually quite a good option. The other first generation, which we don't actually use anymore, is chlorpromazine. So if you do see chlorpromazine, you should not be using that, certainly not as a long-term drug. This is very sedating, and that's that zombie picture that they always have of patients on antipsychotics, lots of very strong anticholinergic effects, but it might be used by a psychiatrist in short-term periods when you need that sedation. So then we've got our second generation antipsychotics, and they're also not without their problems. So risperidone, by far our best other option when haloperidol is not our option, a little bit less of those epilepsies, for example, slightly higher risk than olanzapine, but still much less so than haloperidol. Now, risperidone can definitely interfere with prolactin, and therefore sexual dysfunction can be an issue. Again, our young men are not going to like that very much. And the big problem with risperidone is that it has these metabolic side effects. So if you're on risperidone for years, you're going to gain more weight, you're going to get hypoglycemias, you're going to have a higher risk for dyslipidemia. Also more common on the olanzapines, but we certainly see that within risperidone more so than haloperidol. Does sedate a little bit, but not terribly. Giving it at night normally sorts that out. And then you do have this funny thing of this orthostatic hypotension. So just good to remember, can be a bit alarming when you take your tablet for the first time and you passed out. It is one of those drugs that haloperidol has a bit of an issue in terms of epilepsies in our young men, for example. And so actually in our young men, we do like to use risperidone as our first choice. And then olanzapine, yes, so we have olanzapine as an option now, much more for our acute management of psychosis. And it's recently been brought into the EML because it's amazingly sedating, but it's not as problematic as the benzos in terms of acute psychosis for psychotic patients. The challenge with olanzapine is it's not a great long-term drug. So you would not usually use it as a long-term option if you've got your risperidone. It's definitely much more sedating. It's got significant metabolic side effects as well. Epilepsy is a little bit less common, but it's got more anticholinergic effects, and it's generally just not a nice drug to use as a long-term drug. But we will use it definitely in our patients who are psychotic, in our elderly patients who's also psychotic, or our pregnant patients with psychosis. Olanzapine will be our first choice. There is clozapine, and I'll mention clozapine here, but only specialists will prescribe these, so I don't want to go through all the risks with clozapine. It needs to be very closely monitored, also an old drug, and they use that for what they call resistant schizophrenia. So at the point where neither your haloperidol or risperidone is doing the trick, you're going to be referring this patient to a psychiatrist, and they will have to monitor them closely for the side effects. Then we also do have our injectables, which are from the thiaxanthine class, and there's two major ones that's available. So there's good old-fashioned Depixol, Both the EPSIs are always a problem with our antipsychotics, not too terribly with the injectables, but the risk is there, so we've got to keep an eye on them. And the Dipixol is the less sedating, but also less strong one of the injectables. So if somebody is not too severely ill, Dipixol can work quite nicely. Similar issue with sexual dysfunction we've got to watch out for. But what's quite nice with the Dipixol is also got a mild antidepressant effect. So if you've got somebody who's got milder symptoms, fairly stable, but they also have got a little bit of depression, then you can use your injectables. Because we're worried about things like the EPSIs, we would never start somebody straight off on the maximum dose. So normally you would have tried your haloperidol first to make sure they tolerate them. And even then, when you're introducing this, you would start with half the dose before you would increase it to the full dose. So clopixol we would use in our patients that are more aggressive. It can actually also be used in actual sedation of patients, only under psychiatric use. But they have a slightly higher risk of EPSIs, and patients don't like that if they're feeling very doped up by it. And it's also got less mood effects. So usually we will reserve clopixol for patients who've got quite severe agitation or aggression and where we don't particularly need to manage depressive symptoms. So please just avoid in patients who's over 65 years old. Remember, they do take a while to kick in. So usually you would stabilize your patient first on something like haloperidol before you would actually give them the injectables. And we've got to watch out for the EPSIs. And the problem is if they do develop extrapyramidal side effects, obviously you can't just remove the drug out of the system. So these are the patients we would then use orphanedrine at that point. And they are, although they're a little bit sedating and they're a little bit old-fashioned, they're still not as bad as chlorpromazine, and they're a good option for patients who are struggling with compliance. So just a word about benzos. Benzos are generally not good for psychotic patients, not in acute psychosis and also not in chronic psychosis. They can make patients more confused and more muddled, but occasionally we have to use them if we don't have that olanzapine available for sedating an acute psychosis. So actually in the EML, they've removed IMI midazolam, IMI haloperidol, and IMI promethazone for the use in acute psychosis, and we're actually moving much more to olanzapine. So just a word about all these side effects. So what do we mean by extrapyramidal side effects? And there are early ones and late ones. The most common ones are, so from our first generation, haloperidol, and from our second generation, risperidone. They don't seem to be class specific, and also injectables can all cause bits of EPSIs. And just as a word, we don't add, so you treat them with anticholinergic medicines, but we won't add those routinely just in case to prevent. So you would wait to see that somebody's actually developed problems before you would add in your anticholinergics, because they've got their own problems. And there are particular groups that's more at risk of developing EPSIs. So if they have already a medical condition, especially epilepsy or dementia or a quite late onset of psychosis, they're more likely to get these side effects. There's a higher risk of acute dystonia in our young males. Remember, that's why we tend to and because there's a higher risk in haloperidol than risperidone, we tend to then use the risperidone rather in our young males. And people have bipolar disorders. So if you concomitant treatment, if you're having both on lithium as well as the haloperidol or risperidone, there's a higher risk of getting these. And there's lots of different ways in how they can present. So the one that's probably the most alarming is what they call acute dystonic reaction. And it's a sustained muscle contraction, especially around the face and the neck area. It's a twitching and repetitive movements, and they can actually have the eyes rolling back and the neck. And the worry is if they get laryngospasm, that they actually can't breathe. So it can actually be life-threatening, and patients need to be warned about this. And to remember, it's actually very painful, and it's really scary. So if you've got somebody who's already mentally quite vulnerable, to have something like this can be an absolutely terrifying experience. And so we have to talk through that quite nicely. More in terms of the long-term use of it, you can see a Parkinsonism, especially seeing in the gait, and sort of a masked faces and a pill-rolling tremor. And the most common we see as a side effect of the antipsychotic drugs is this muscle rigidity and tremor. And very important that if you are on treatment, you actually want to stop those treatments that are causing those and get them onto some of those anticholinergics. And then you get something called akathisia, which the patient would describe as a subjective, unpleasant state of inner restlessness. So they have a real need to move. It's like jiggly legs, but in overdrive. And what it might look like is that they are restless. They're pacing or rocking or marching or crossing and uncrossing their legs because they have this very uncomfortable inner feeling of needing to move, and can also be very disruptive. So how do we manage these three things? So for acute dystonic reactions, we use piperidine, IMI. It is in the EML, and you can give 2.5 milligrams every 30 minutes, but a maximum of 3 dosages within 24 hours. So you want to get that until you've actually managed to manage that reaction. If you don't have piperidine, you can also use promethazine. For the Parkinsonism, that's where orphenadrine comes in, the role of orphenadrine comes in, but please do stop the drug that's actually caused the problem, and you're going to adjust your dosing depending on what's needed for that patient. So the problem with orphenadrine is it's an anticholinergic, so especially in the elderly, it can actually cause confusion and urinary retention, so that's why we don't like to use it routinely. And then for the akathisia, please stop the offending drug. And then propranolol might be quite useful just to help for those symptoms. You'll start with 20 milligrams and titrate up, and just keep an eye on the blood pressure and pulse and make sure they don't end up starting to get faint or dizzy. Then you get late episodes that present later on, and the one that's often talked about is this tardive dyskinesia, fortunately quite uncommon, but they get these choreathetoid involuntary movements that involve the face and the lips and the tongue quite often. So it can be lip smacking or chewing, tongue protrusion. Occasionally it also affects the arms, the legs, and the trunk. More common in our older women, and then, as we've said before, people with bipolar disorder or people with cognitive impairment. And just to note, only 50% of these are reversible. So this can become lifelong, which can be very, very unpleasant. So if a patient had early epilepsy, so they had one of those dystonic reactions, for example, they're more likely to develop something like this later on. So we actually ideally then want to try and avoid the drug in that person. And then you get your anticholinergic side effects. So that's oral chlorpromazine, haloperidols, olanzapine can all cause a bit of anticholinergic side effects. And that includes urinary retention, blurred vision, dry mouth and eyes. We don't have to worry too much about that. And constipation, that is usually also self-limiting. But certainly if they're starting to get urinary retention or they're getting blurred vision, we would have to stop those treatment and look at other options. And there's that little mnemonic for your anticholinergic side effects: hot as a hair, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. The last one that we have to discuss, luckily very, very uncommon, that's your neuroleptic malignant syndrome. Usually after either haloperidol or risperidone, can also happen with the injectables. And again, if you're combining these with other antipsychotics, they're at a higher risk of developing this. And what happens is that they develop actually a whole global autonomic instability that presents as agitation, dehydration, exhaustion, and iron deficiency, and they can actually occur with a very high fever. So they have this tetrad when you look at them, with fever, muscle rigidity, altered mental state, and autonomic dysfunction. So the blood pressure might be very low or very high or going up and down. They might also have an altered mental state, which can be difficult if it's a psychotic patient to then figure out what's going on, but that'll be more confusion, delirium, or stupor that you're seeing. There's not actually anything you can give to counter these drugs. You're going to have to stop the offending drug, do a CK to help you with your diagnosis, and you're going to manage it by stopping all of the treatment that they're taking, cooling the patient down, hydrating them, and treating them symptomatically, and you need to do all of this under admission. Thank you very much. In the next tutorial, we'll put it all together in terms of firstly acutely and then secondly the chronic management of patients with schizophrenia.